Welcome to part 3 of my endocrinology series. My name is Dr. Betty Dube and my pronouns are she, her. This part will be covering insulin. I've included this captioning statement just in case you do use the captioning in this recording. Just note that it is up to 90% accurate. So the learning objectives for this part is to review the insulin timeline. We'll also explain the mode of action, cautions, the contraindications, and side effects of insulin. I'll also describe the insulin profiles as well as the different products and, importantly, safety information. So insulin, again, just to recap, is a hormone produced by the pancreas to regulate glycemic levels in the blood. It is synthesized in the pancreatic beta cells initially as a polypeptide precursor, pre-proinsulin. It circulates free as a monomer and has a half-life of between 3 to 5 minutes. It is primarily metabolized by the liver and kidneys, and in the kidneys, insulin is filtered by the glomeruli, and it is reabsorbed by the tubules and degraded. The interaction of insulin with the receptor on the cell surface sets off a chain of messengers within the cell, opens up transport processes for glucose, amino acids, and electrolytes. An acute deficiency causes uninhibited hepatic glycogenolysis as well as gluconeogenesis, causing increased hepatic glucose output and increased glucose uptake, leading to hyperglycemia. At the bottom here, I've just put a reminder of what a hormone is, as well as the differences, like we covered in part 1 of this series. So type 1 diabetes pharmacotherapy involves insulin because it presents as a deficiency of insulin, where there's an eventual loss of pancreatic beta cells. And remember, I did say when the function is between 5 and 10% is when the person would present with the symptoms. So patients require lifelong insulin. Exogenous insulin is used to mimic the normal physiological pattern of insulin secretion as closely as possible for each individual patient. A balance is required between tight glycemic control and hypoglycemia risk. Hypoglycemia is low blood glucose. If the risk is high, it is necessary to aim for a less tighter glycemic control, and this is something we'll discuss and revisit as we're going through the case studies. All the currently licensed insulin products are available by injection only. For some of you, you might remember that there was a nasal spray that was registered for use some years ago, but it just wasn't as effective as it should be, so it was withdrawn from the market. That gave an alternative formulation. Okay. So I thought I'd include this diagram here again, just as we covered in the last lecture on the pathophysiology of type 1 diabetes. So in a healthy pancreas where the beta cells are working, insulin is produced, and everything is all normal, where the glucose is taken up as needed and vice versa. But when in type 1 diabetes, there is no production of insulin in the beta cells, so you have more glucose in the system and the blood sugar. So you need the insulin to counter this effect, and that's why insulin is needed as a treatment for type 1 diabetes. So let's take a look at the insulin as a medication. So it is the exogenous insulin that works by mimicking a normal physiological secretion pattern. Insulin is given by injection only, either subcutaneously or intravenously. The main caution is hypoglycemia, which is an inevitable risk with insulin therapy. Interactions include medications that also lower glucose, such as clarithromycin, sulfonylureas, as well as SGL2 inhibitors and the DPP4 inhibitors. Side effects include hypoglycemia, and others are related to the injection site, so skin reactions, and also conditions like lipodystrophy and cutaneous amyloidosis, rather. Also to note that an overdose of insulin does lead to hypoglycemia. And to note also is that the storage of insulin is in the refrigerator, and once it's open, it may be stable for a few weeks, depending on the manufacturer's recommendations. Next, I wanted to revisit the timelines for insulin. So insulin was first discovered in 1921, and it's termed to be the greatest scientific achievements of the 20th century. The development of insulin in a purified form happened in the late 1970s, and then the human insulin did come to the market in the 1980s. This resulted in a dramatic reduction in allergic reactions and lipoatrophy of the injection site. Introduction of the first generation insulin analogs, such as insulin lispro, occurred in the mid-1990s, and something like insulin glargine in the early 2000s. These both were another important advancement for the treatment of type 1 diabetes. So here's the timeline of how this all happened. I thought I'll include it here for completion. All through when the research started in 1921, where you had Banting and Best that worked on this insulin product, but there's also research that was fed in by MacLeod, who came from Aberdeen, and I will be talking about next. And then there's the timelines all through. Just use the pointer here. As you can see, what I was talking about earlier, take a few moments to have a look at this. Certainly pause this part so you can have a look. It just goes through the whole timeline, all through where we are now. And this ended in 2021. But you can see that the research is ongoing, and just in the 2000s. Now in 2005, they've included here the GLP-1s, which apparently they are trialed out for type 1 diabetes. And then also some SGLT2s have been used for type 1 diabetes. And there's more future possibilities here. So research is ongoing. Okay. So I thought I'll discuss the first person who ever received a dose of insulin. So since the discovery in 1921, again, it's one of the greatest scientific achievements of the 20th century. Leonard Thompson was the first person to have received an injection of insulin as a treatment for type 1 diabetes. So Thompson received his first injection in Toronto, Ontario, and that's in Canada. And that was on the 11th of January 1922, and he was 13 years old. The first injection had an apparent impurity, which was likely caused the allergic reaction that he displayed. Then they had to refine it, and somebody called James Collip improved this canine pancreas extract, and the second dosage was successfully delivered to this patient 12 days after the first dose. So Thompson showed signs of improved health and went to live 13 more years taking doses of insulin before dying of pneumonia, sadly, by age 26. So before insulin was made clinically available, a diagnosis of type 1 diabetes was a death sentence, more or less quickly within months and frequently within weeks or days. Again, as you can remember, that acute deficiency that does occur once the beta cell function is below 10%. And then, so this was really, as it says here, death sentence. And Leonard Thomas was our first insulin patient. That's really exciting. But then I thought I'd also share this for those of us who are not aware of this, that we have the first ever monument honoring Aberdeen's insulin pioneer that was unveiled at Darthy Park on October 12th of 2023. This memorial stands in tribute of R.J. MacLeod, who co-discovered insulin in 1922. So he took his research from the University of Aberdeen and went all through to the University of Toronto in Canada, where he and Banting and Best completed the work. Okay, this is meant to have. Okay, there's for those of you who are close to Aberdeen, you can go and have a look there. I've always said I'll take a photo on this bench, or maybe I will have one before I finish off this set of lectures this year. So it's the first storytelling statue in Scotland, and we're proud to host that in Aberdeen. Okay. So insulin therapy. All patients with type 1 diabetes do require insulin, but the type and manner of delivery differs among patients, clinicians, as well as the resources and the formulary allowance. Therapy should attempt to match carbohydrate intake with glucose-lowering processes, usually insulin and exercise. Dietary intervention should allow the patient to live as normal a life as possible, All patients receiving insulin should have extensive education in recognition and treatment of hypoglycemia. The timing of the insulin onset, peak, duration of effect must match meal patterns, exercise schedules to achieve a near normal blood glucose values throughout the day. So that's really important. Okay. So insulin products. In the UK, there are three main categories of insulin products. First, we have the human insulins, which are created using recombinant DNA technology. They have the same amino acid sequence as the insulin naturally produced in the body, or in the pancreas rather. Next are the human insulin analogs. These are also engineered, but with small modifications to the insulin molecule to achieve certain desired characteristics. For example, faster absorption or longer duration of action. And thirdly, they are the animal-derived insulins extracted from bovine or porcine sources. So bovine will be from cows and porcine will be from pigs. These were widely used historically but are now rarely initiated. They remain available only to patients who cannot tolerate or do not wish to switch to synthetic or analog preparations. Altogether, there are now over 25 different insulin preparations that may be prescribed in the UK. So here's a chart of the insulin nomenclature I thought I should include here. So we have the type of insulin, the description, and the additional information. This is a slide you might have to pause to have a quick read of, but I'll quickly skim through here the different types. We have the endogenous insulins, we have the human insulin, then we have the short-acting soluble insulins, we have the intermediate acting ones, we have pre-mixed insulins, we have analog insulins, rapid acting analog, and long acting analogs. So these are really important. As you read through the descriptions there, tells you exactly when these should be used and how quickly they act. I have another slide here that shows this in a more colorful way. So I thought I would use that to explain these differences. Okay. So when it comes to the insulin profile, the natural profile of insulin secretion consists of two components. Okay, so first is the basal insulin, which represents the constant low-level background secretion that controls glucose released by the liver throughout the day and night. The level dips slightly overnight and then rises before dawn. And then the second component is the mealtime bolus insulin, which increases sharply in response to carbohydrate absorbed from food or drink. Together, these two components form the physiological insulin profile we aim to imitate in type 1 diabetes management. And this is why you would see the regimens or the protocols for the treatment of type 1 diabetes rather vary, because we're trying to mimic the endogenous insulin, the natural occurring insulin profile. So again, here are the types of insulin. So we have the regular insulin, which has a relatively slow onset, meaning it needs to be injected around 30 minutes before eating to ensure adequate post-meal glucose control. In contrast, we have the rapid acting insulin analogs such as Lispro, Aspart, and glulisine that are absorbed faster and have a quicker onset and shorter duration. This allows them to be taken much closer to meal times, often within about 10 minutes of eating. Okay. Because they mirror normal physiological spikes more closely, they are generally more effective in reducing postprandial blood glucose levels. Okay. And then we have the neutral protamine hedged on, the NPH, which is an intermediate acting insulin that provides longer coverage, but it can be variable in how it is absorbed. This can lead to inconsistent glucose control, nocturnal hypoglycemia, or fasting hyperglycemia. The next are the long-acting analog insulins, such as glargine and determer, that were developed to overcome these issues. They offer flatter, more predictable profiles with less pronounced peaks, reducing the risk of nighttime hypoglycemia when taken at bedtime. Okay. So when we go into the different insulin regimens and products, so in managing type 1 diabetes, there are three main approaches to insulin regimens. The first is the multiple daily injections, often referred to as the basal bolus regimen. This includes a basal insulin, either intermediate or long-acting, combined with a rapid-acting insulin dose before meals. This method provides flexibility and closely mimics physiological insulin delivery. The second option is the biphasic or mixed insulin regimen, combining short-acting and intermediate-acting insulin in a single injection. Depending on the patient needs, this may be administered once, twice, or 3 times daily. The third option is the continuous subcutaneous insulin infusion or insulin pump therapy. This uses rapid-acting insulin delivered continuously through a programmable device, showing fine-tuned adjustments throughout the day. So this really is another advancement in the management of type 1 diabetes. Put here a link to the NICE guidelines that covers this part of the treatment of type 1 diabetes. So this is what I just spoke about earlier, but I thought I'll have it in a table, as in a comparative table that represents a more detailed breakdown of the insulin types. So it includes the endogenous insulin, which really is not a product. So that's what's already produced by the pancreas. Then we have the human preparations, we have the analogs, and the UK licensed product. It summarizes the onset, duration, typical use, which can be helpful reference when selecting the most suitable regimen for each patient. So it tells us here exactly what it is, a brief explanation, and the products that are currently available in the UK, and it also includes the manufacturers just for completion. I would recommend that you pause this video and have a quick look at these different products. Okay. I think it's noted here that the supply of Levermere will change as of 2025. So that was last year, but certainly I'll talk about that when we get to the safety information of the products. Okay. So I'm a visual learner and I really like this table that summarizes everything, but it also shows you the typical activity of the products and how they actually are covered, or how they cover the body throughout the day. So again, I would recommend that you pause this slide, pause the recording and have a look at this slide. It breaks it all down to each product as available in the UK. It highlights how basal bolus therapy, premixed formulations, and pump therapy differ in timing, flexibility, and intensity of management. It's really important. More on products here. Again, it's just a different kind of presentation, but it's also telling us how they should appear. And this is one of the checks we would do as pharmacy professionals when we are giving out an insulin product or completing a medication reconciliation. There's a short video here about insulin that was put on TikTok, and I thought it was quite good as a summary when we're trying to remember which one is which. Okay, and take a few minutes to also watch that video. Okay. Now I will move on to the basal bolus overview. So the basal bolus concept aims to replicate normal physiology by giving longer acting insulin to provide background coverage and rapid acting insulin at meal times. This intensive therapy is recommended from diagnosis in adults with type 1 diabetes, emphasizing early tight glycemic control to prevent long-term complications. Okay. So the basal component option includes a once or twice daily either MPH, twice daily Determere, or a once daily insulin aglaudine, the long-acting one. Most patients with type 1 diabetes will need more than one basal injection per day, with the exception of those using glargine, and there's also other newer products in the market that are long-acting. Okay. Again, for the basal bolus dosing, The mealtime bolus component is delivered using regular insulin or rapid-acting analogs such as Lispro, Aspart, or glulisine. Rapid-acting analogs are particularly useful because their quick onset and short duration allow patients to adjust doses based on blood glucose, expected carbohydrates, and anticipated physical activity. Carbohydrate counting is a key strategy here for personalizing bolus doses. Okay. At a starting point, the total daily insulin dose is often estimated to be around 0.6 units per kilogram. About half of this is basal insulin, with the remaining half divided into pre-meal doses, typically weighted slightly more toward breakfast. More adults ultimately require between 0.5 to 1 unit per kilogram per day, adjusted according to glycemic patterns. Again, this is how it will be calculated. So you have the 50% as the basal, and then the boluses are calculated with the rest of the 50%. As I mentioned, the breakfast one will be given a higher weight, so that's the 20%, and then we'll have 15% before lunch and 15% before dinner. So that is the typical dose again for patients. So again, important here, we'll have to know the weight of our patient before we're able to dose them appropriately. Okay. So pump therapy or continuous subcutaneous insulin infusion offers the most nuanced way to deliver insulin. Rapid-acting insulin is infused continuously, and the basal rate can be adjusted throughout the day to match changing insulin requirements. Pump therapy offers improved glycemic control for carefully selected patients, but it requires high engagement and frequent monitoring. As you can see here, it may not be the best for everybody. Okay. This slide, I've put a link to a short video demonstrating the insulin types and key considerations, as well as practical guidelines, devices, and administration techniques for vital, safe practice. Again, I recommend that you take a few moments to watch this video. Okay. So how is insulin administered? Okay. In order to reduce the risk of insulin errors, we must remember the right insulin in the right device at the right dose, in the right way at the right time, the right way. So insulin should be injected at a 90-degree angle. You can use the upper, outer thighs, buttocks, abdomen as injection sites, just as demonstrated in this diagram here. Those are the typical injection sites. Vary the places you inject to avoid the development of fatty lumps. Those are the lipohypertrophy, which will delay insulin absorption. One must change the insulin pen needle every time they inject. So it is a disposable needle, it's not reusable. And these must be discarded in a sharps bin. There's a short video here regarding this injecting of insulin. Again, as pharmacy professionals, you can complete training to become injection certified, and this is certainly something you could assist your patients with. I have done that in my previous practice. I thought I would delve into the important safety information with regards to insulin. So at the NHS Improvement Patient Safety Alert from 2016 said there was a risk of severe harm and death due to withdrawn insulin from pen devices. So insulin should not be extracted from the insulin pen. So the pen must be used as is, and you can never substitute the pen with anything else. So you can't, I think there was sometimes when somebody has a pen or they're used to the vial and they receive the wrong and they're like, oh, I can just use one for the other, but that is a absolute no-no. Because the strength of the insulin in the pen devices can vary by multiples of 100 units per ml. Insulin syringes have graduations only suitable for calculating doses of standard in 100 units per ml. If insulin extracted from a pen or cartridge is of a higher strength, and that is not considered in determining the volume required, it can lead to a significant and potentially fatal overdose, because then you'll be calculating it using different units. So the NHS never event overdose of insulin due to abbreviations or incorrect device. This was reported in January of 2018. So the words unit or international unit should not be abbreviated ever. Specific insulin administration devices should always be used to measure insulin, so insulin syringes and pens, and insulin should not be withdrawn from an insulin pen or pen refill when administered using a needle. So these are all really important. Okay. And to the next slide. See, it lets me do that. Okay. So I thought I'd include this safety alert here, the SureMed alert from King's College Hospital. Again, it lists there the insulin and how the wrong dose was given. So this was an alert that was rolled out at that NHS board. So it's really important when these incidences happen that we get to learn from them. And I do like the fact that we can, everything is disseminated so that we can all learn from these, and then so that we don't make the same mistake. So that's really important. Okay. So I thought I'd include this update here from Novodisk. It has decided to discontinue Levemir, which is insulin determere, globally, and the UK supplies of the Levemir FlexPen and Penfill are expected to be exhausted in the UK by 31st December 2026. So key advice for us as pharmacy professionals is we're not longer initiating new patients on Levemir because the supplies will be out by the end of this year, and there is not a likely switch of like to like for insulin detriment. So patients will need to be carefully switched, and additional monitoring will be important at this stage. Okay, so insulin switching will involve switching the pen device. It will require monitoring for the adjustment and potentially dose reduction while transitioning to a new insulin. This discontinuation is being managed nationally with local oversight. So for those of you who work in this space, you will see maybe something has come through. But what I also included here is the Novodisk alert to say that they are discontinuing this product globally. Okay, so the safe handling of insulin. Insulin ranks among the top 10 high alert or high risk medications worldwide. And there's a report here from our National Patient Safety Agency. It received many, over 16,000 reports of incidents involving insulin here, and 7% of those were associated with significant harm, and 18 ended up with a fatal or severe outcomes. Okay, so that's really important for us to be aware of what's going on out there, because the statistics are a bit dated, but I can say they are still relevant today as a learning for ourselves. So to avoid errors with insulin, so some of the main ones that were reported in those reports were incorrect prescription and admission, the use of abbreviations, incorrect monitoring, poor documentation, duplicate dosing, error in calculation, as well as incorrect programming of those electronic infusions. Okay, so caution to us as pharmacy professionals is that we must always triple check when dealing with high risk medications, not just insulin, but any others that we may deal with. Okay, so insulin management tips. An intensified treatment regimen for adults should include either regular human or rapid acting insulin analogs, as I mentioned earlier. Basal insulin analogs are recommended for adults who are experiencing severe or nocturnal hypoglycemia, so that's hypoglycemia overnight, who may be using intensified insulin regimen. Those who are not experiencing nocturnal hypoglycemia may use basal analogs or NPH insulin. So this is done case by case. But this is different when we look at children and adolescents. They can either use the insulin analogs, rapid acting and basal. They can use the regular insulin or the NPH preparations at an appropriate combination of these. Insulin regimens should be tailored to the individual child to achieve the best possible glycemic control without disabling hypoglycemia. So the continuous subcutaneous insulin infusion, the insulin pump, is associated with modest improvements in glycemic control and should be considered for patients unable to achieve their glycemic targets and patients who experience recurring episodes of severe hypoglycemia. To reduce the risk of long-term microvascular complications, the target for all young people with type 1 diabetes is the optimization of glycemic control towards a normal level. So that's really important. And we as pharmacy professionals we play a very vital role with the management of type 1 diabetes. I thought I'd move on now to the adjuvants for type 1 diabetes. Again, some of these are available in the UK, some of them are not. And I thought this table does have a clear description of what they are, the indication for use. Again, the status in the UK, so this is different. Like metformin is currently not even recommended by NICE in the UK. Then we have another drug here, not even available in the UK yet, but it has been used in the United States. And then the SGLT2 inhibitors were said they might be used for adults, but some of them have been withdrawn for use in type 1 diabetes. And then we also now have the upcoming GLP-1 receptor agonists. All these drugs I will be reviewing when I cover the pharmacotherapy for type 2 diabetes. Again, these GLP-1 receptor agonists have been investigated for type 1 diabetes, for people with type 1 diabetes and obesity, but they're currently not approved in the UK. And then we also have the monoclonal antibody teplizumab, which is at stage 2 type 1 diabetes to delay progression and currently approved in the EU, but in the UK, one can gain access through the ongoing trials. Okay, so adverse effects of insulin. So what happens when you have too much insulin? So hypoglycemia is the main known side effect of insulin, and it presents as neurogenic or neuroglycopenic symptoms. So the neurogenic ones are either adrenergic, cholinergic mediated, and these will include the tremors, feeling of anxiety, hunger, and sweating. And then you have the neuroglycopenic symptoms that are a result of the brain neuronal glucose deprivation. These include warmth, weakness, difficulty thinking, confusion, tiredness, and drowsiness. Okay, so these are important for us to educate our patients on insulin about these. So the treatment of hypoglycemia is, I thought I would include this here. So we have different so we have the mild hypoglycemia where somebody is still awake, they can treat themselves. And importantly here, they need a rapid acting carbohydrate to be taken by mouth right away. So it should be at least between 15 and 20 grams of a rapid acting carbohydrate. Okay, and then this could be any of these here. So 4 large jelly babies, 200 ml of concentrated orange juice, or 2 tubes of glucogel, or 4 to 6 glucose tablets. Again, this is something people with type 1 diabetes are educated to have on their person in case this does happen to them, so that they can have a quick glucose uptake. And then they have to recheck their blood glucose within 10 minutes. And if it's less than 3.5, they have to repeat the carbohydrates. If it's above 3.5, then they follow with a 20 gram of a medium acting carbohydrate, such as bread, biscuits, milk, or next meal. Okay, then this is repeated again. So the testing here becomes really important. Okay. Now, if it's severe hypoglycemic and unable to self-treat, they cannot swallow, definitely call 999 and place the individual in the recovery position. This is when we'll have to say, do they have a glucagon hypo kit? Is that available? Can somebody use it? And all that. Okay, and then this is what the protocols to follow. So most people with type 1 diabetes will have for example, glucose tablets, but they will potentially also have the glucagon kit for hypo emergencies. Okay. So this is a colorful algorithm for the management of hypoglycemia in adults with diabetes in hospital. Again, I've included this here for completion. for you to see how this can be managed, because hypoglycemia is a serious condition and should be treated as an emergency regardless of the level of consciousness. So even when the person is still able to self-treat, they must treat. So it is defined as a blood glucose of less than 4.0 millimoles per liter, okay? And they are symptomatic as well. So this again varies. We have some people with a higher threshold and a lower threshold, but every person gets to know themselves and to know what their threshold is. So here again, you can pause this video and have a look at how this will be treated in a hospital setting. Importantly there, it's in a hospital setting. Okay. So target blood glucose and self-monitoring of blood glucose. So what is it? It's indicated in most patients with insulin-treated diabetes, but its value is limited unless the user self-adjusts their insulin doses according to results. So it is an integral part of the treatment for everyone with type 1 diabetes, because most of them or all of them will be on insulin, and access to blood glucose testing trips and meters or the flash glucose devices should not be restricted. So again, this is from Diabetes UK. So they're advocating for all patients to have those. And luckily, under the NHS, I think these are all covered. It should only be started when there is a clear need and purpose agreed with the user and with instructions and education with regard to appropriate testing, timing of the test, and how to act upon results. So it's not recommended in patients who are reluctant or in whom it will have little influence on management. Patients should be encouraged to test minimally to achieve and maintain good glycemic control. So target blood glucose should be between 4 to 7 or as individually agreed with the patient. Again, it is case by case. I've included here a link to the NICE Guideline 17 chapter on recommendation for blood glucose monitoring for you to have a look at. So when it comes to continuous glucose monitoring, so all adults with type 1 diabetes should be offered a choice of real-time continuous glucose monitoring or intermittently scanned continuous glucose monitoring. So there's two options there. There's the flash and the RT. Okay, based on the individual preference, needs, characteristics, and the functionality of the devices available. Okay. Again, review examples of factors to consider as part of this discussion that is within our NICE Guideline 17. When choosing a continuous glucose monitoring device, shared decision-making must be used to identify persons' needs and preferences and offer them an appropriate device. If multiple devices meet their needs and preferences, offer the device with the lowest cost. Note that in areas without universal healthcare, cost is a major barrier. I've included this here because I know in the UK, we are under the NHS and the NHS does cover this, but in my previous practice in Canada, these were not covered. I mean, it's not universal healthcare, and it depended on what you could afford for you to be able to get the therapy that you need. So continuous glucose monitoring covers both real-time and intermittently scanned continuous glucose monitoring. A continuous glucose monitor is a device that measures blood glucose levels and sends these results to a display device or a smartphone. So now with technology, this has all been integrated, and it's really good that even some patients get to share these results with their diabetes team. That way they can monitor them much more closely. Again, there's a link to the NICE NG17. So accuracy of the device is another factor to consider, and also if the device provides predictive alerts or alarms, or if these need to be shared with anyone else, for example, a carer, whether using the device requires access to particular technology such as a smartphone and up-to-date phone software, how easy the device is to use and take readings from, including for the people with limited dexterity. So that's something to always consider. Fear, frequency, awareness, and severity of hypoglycemia is something to consider as well as psychosocial factors. So the person's insulin regimen or type of insulin pump is, if relevant, take account if the particular device integrates with their pump as part of a hybrid closed loop or insulin suspend function. So these are quite niche in their own right, but I thought I'd mention them here for completion. Whether, how often, and how the device needs to be calibrated, how easy it is for the person to use it themselves. So it's very important for us to be able to educate the person on the best device for them to use, but also that works for them. because it could be really good on paper, but if it's not fit for purpose for that particular patient, then they will not use it appropriately, and it may not fit their purpose. Okay, also other factors to consider: how is that data collected, how compatible it is to other technology, and should it be shared with the healthcare professional to help inform treatment, whether the device will affect the person's ability to do their job. So some of them are quite, I think you may have seen them, and I have a video showing those. It just depends on the job the person has, how predictable the person's activity and blood glucose levels are, and whether erratic blood glucose is affecting their quality of life, whether the person has situations where symptoms of hypoglycemia cannot be communicated or can be confused, for example, during exercise, clinical factors that may make devices easier or harder to use, frequency of sensor replacement, sensitivities to the device, for example, local skin reactions, because there's something you have to continuously wear. And also, we also have upcoming body image concerns, especially for the younger generation who have to use these devices. This has to be considered. Okay, so target blood glucose is important for us to be aware of, and I thought I'd include this. Here's the blood glucose self-monitoring guideline, and then it follows the ABCDE algorithm here. But importantly, also for monitoring, alongside the self-monitor of blood glucose, the measure of HbA1c levels every 3 to 6 months in adults with type 1 diabetes is recommended, and this has a target of at least 48 millimoles per liter or 6.5% or lower, which minimizes the risk of long-term vascular complications. So when somebody's on insulin injections, the minimum is to test is at least 4 times a day, and that really coincides with them having the pre-meal insulins, the rapid acting, and then the basal one, which will be once a day. Okay. So adherence to insulin therapy is generally poor, and this is what the studies have shown. And few factors or patient-perceived barriers are consistently identified as predictive for non-adherence, although findings collectively suggest that a more flexible regimen may improve adherence. And this is where that shared decision-making becomes really important. I've included a link here to an article that will show some insight on real-world factors affecting adherence to insulin in both type 1 and type 2 diabetes patients. Okay, so I thought I'll move on to when and where they will have a typical care plan for a type 1 diabetes patient. So they're normally under care of a diabetic team, and where and when they have their diabetes education is important, and this must include dietary advice. Initial treatment is important, including guidance on insulin injections and the regimens they must follow. Self-monitoring and targets are important. Symptoms and the risk of hypoglycemia and how this can be treated. There is also management of special situations, for example, driving, as well as communicating with their diabetes professional team, how often and how to contact them. So NICE Guideline 17 and the BNF covers this quite extensively, and I would recommend that you have a look at this. Okay. So there's also management of cardiovascular risk. So we will I'll recommend that you have a look at the section on control of cardiovascular risk. Implications for pregnancy and family planning advice, and this is for women of childbearing age, and this is covered in NICE Guidance 3. How often will they follow up appointments, and what will these cover? Okay, including reviews of any of the A1C levels, experience of hypoglycemia, and also annual reviews. After the initial plan is agreed, it should be implemented without appropriate delay. Based on the discussion, then adults with type 1 diabetes, the plan has to be modified over the following week. So again, it's not written in stone, just like most therapies are not. This has to be individualized to the patient. Okay. Very important for us as pharmacy professionals is to signpost and educate the patient. So we have diabetes care, the alphabet strategy approach is one that has been used, and we'll cover it in the next series. We also have diabetes care education. We have Diabetes UK, which some of the videos we watched in the previous lesson from them. We also have the My Diabetes My Way, and it's a good platform where patients can get join a community of others with diabetes. We also have the Bertie Type 1 Diabetes Education Program, and then there's also Daphne. Okay. I thought I'd include here just ongoing research with regards to the adjuvants of type 1 diabetes. Again, just for completion here, as you can see, there's the ELSA trial, there's the teblizumab trial, there's the beta preserve trial, and there's the fabulimnas trial. And also this year there's a big type 1 diabetes grand challenge, and I'll include a video of it in the Moodle page. And there's also global regenerative therapies that are upcoming. Okay, just to summarize, so type 1 diabetes, you have a destruction in the beta cells which causes insulin deficiency here. As you can see, the pancreatic cells, you have not enough insulin, so this reduction in glucose utilization affects the adipose tissue, so there's enhanced lipolysis, free fatty acids due to insulin deficiency. You have enhanced protein catabolism. Then you end up with the glucogenesis that results into the diabetic ketoacidosis here, because there's a bigger production of ketones. There's hyperglycemia in the kidneys. You have ketonuria and glycosuria, so ketones and glucose in the urine, and you have polyuria here. Volume depletion potentially can lead to a diabetic coma if not treated. So I thought I like this snapshot that sort of tries to simplify quite a complex process, if you like. Okay, and that's in type 1 diabetes. The other side, we have what happens in type 2. I will cover that in the next lecture. Okay. So again, another summary for the management of type 1 diabetes in an adult. So I'll recommend that you pause this video to have a look here. It's a report that was published in 2021, and I thought it just gave a pictorial representation of an adult with type 1 diabetes, the complications and all the organs that are associated with that, and why it is really important for that tight glycemic control with insulin. Okay. And here are the resources and references that I use for this section of my series. Again, most of these are live and you can pause and use them, and I'll also have them in the slides if you want to have a look at them after listening to me. So next, we will be covering type 2 diabetes. We'll also be covering diabetic emergencies and major complications of diabetes. So I hope you will enjoy those. Again, for any questions, please post on the module Moodle page, discussion forum. Thank you again for listening to me.